Welcome back to the Lift Free and Diet Hard podcast. I'm your host, Andrew Coates. Join me along with industry leaders and friends on a quest to get more people through the gym door and eating and living healthier. Join me where evidence meets empathy while rejecting fitness industry fads and extremism. Let's begin. Dr. Jordan Feigenbaum, and I will preface that as MD. I don't get a lot of MDs on here, but you guys are great. Certified strength conditioning coach, elite powerlifter, competitive. And you are the face and the main figure behind Barbell Medicine, which is a really great evidence-based podcast educational platform. So it's great to have you on.
Hey, thanks for having me. I think I need to have you follow me around just whenever I enter a room. I just defer to Andrew Coates. He's going to give me the best intro I could ever get, and it'll be great.
I take great pride in that. All right. I pulled a lot of stuff from, I especially like the way that you contradict bullshit on threads in the most charitable way. So, but first one I've got, and I saw you post about this recently. I thought it was fascinating. So, is overtraining real?
Mm. Yeah, great question, right? And I think, we made a podcast about it. Obviously, not great for discovery, right? If you were looking for reach, most people are not Googling like overtraining anything. More of like a pet topic and a pet peeve I've had with the fitness industry at large for a while, because the premise is that it is not only a possibility, but even probable that you can do too much exercise, so much exercise that you will become, what everybody says, overtrained. And that narrative, there's a bit disconnect between that and overtraining syndrome, right? So my thought was if we can kind of debunk is too hard of a word, but if we can come at objectively look at the evidence and discuss overtraining syndrome, perhaps then we can unpack what people really mean by overtraining and then get to a better place. Because the whole, the bottom line is the elevator pitch, whatever you want to call it, is that by and large, it is very, very challenging to do too much exercise to the point where you are no longer responsive to said exercise. I didn't say it's not possible to train so much where you run the risk of an overuse injury. I didn't say it's not possible to do so much training that it interferes with your ability to hold a job and have, meaningful relationships outside of the gym. But true overtraining syndrome is very, very challenging to produce, if not impossible. I'm kind of the opinion that overtraining syndrome, as the diagnosis stands, which is a diagnosis of exclusion, you have to rule out everything else, and it has to just be from doing too much training, is not really a thing. I think it's more likely, based on the current evidence that we have, a function of low energy availability, so just not having enough calories on board, and or some sort of environmental stressor, whether it's sleep deprivation, whether it's psychosocial stress, otherwise, that's ultimately reducing the person's ability to adapt to exercise. And so what you have to see in overtraining syndrome are a handful of things. One, you have to see a decrease in performance that lasts after you pull back the training. Right. And then you have to see no other possible explanation. And so I think when you do those two things, you have people, the documented cases, quote unquote, of overtraining syndrome evaporate. And a lot of this has to do with how do you study this, right? What do you take 100 people who are otherwise healthy, training or whatever, and just ratchet their training load up through the roof and see what happens? To date, we have multiple different experimental designs in resistance training and endurance training where training loads are very, very, very high. You don't see any evidence of this. You see case reports of what people are calling overtraining syndrome, but they don't really meet criteria as listed. And so, again, most people aren't searching for that. And rather when they say they're overtrained, they just mean, I'm tired, And which, hey, been there, been tired. I stay tired, but it's not overtraining syndrome.
And I think we can caveat a couple more things. I mean, you can acutely do too much to where you can develop things like compartment syndrome and rhabdomyolysis. You absolutely have
Sure.
to be careful of that. That's not what you're saying.
Correct.
And you alluded to this, I'll say it more explicitly. You can violate load management principles to where you can increase injury risk, right? That's
Hmm.
I think pretty well established science and evidence. Uh, and here's another thought on it as well. There comes a point where I suppose in hypertrophic stimulus, we see fairly diminishing returns past certain volumes. So there probably gets to a point where the adaptive stimulus just isn't there to warrant continuing. But what about, I'd love to hear your thoughts on that because I traditionally am a bit more of the high volume camp, and now the evidence seems to be kind of pushing back against that. But also, there's not just hypertrophy as a stimulus we're trying to seek. We're also looking for cardiovascular adaptations, which we know we can do at very high volume. So, can you speak to all that?
Yeah, I think, the way I view maybe a training career is probably good groundwork here. It's like if you chart out any sort of adaptive process, whether it's neurological adaptations, whether it's just strength performance, whether it's structural adaptations at the level of the muscle, the tendon, ligament, the bone, they all have a curve. Right. And it really looks like an asymptote, right? It kind of goes up steeply, bends, and then kind of levels off. It's still kind of going up a little bit, but not as much. And they're on different time scales, right? And so what happens as you move further down that scale is the sort of effective training load that you need to see continued adaptations gets higher, but your maximum recoverable training load, because I don't like maximum recoverable volume because that's just one element of training load, those two things get narrower, right? And so you may not have the resources to train that much. And then if you do, to meet that sort of minimum training load, you may not have the resources to recover from it, right? Especially if you go past that. And so I think what you see is two things. What you pointed to, one, diminishing returns stacked on top of diminishing returns on the organism, period, because they're getting closer to their ceiling, right? And then a lack of resources, right? So from my perspective as a coach, and likely yours, even if not explicitly stated, your goal for an individual is to try to get them to do the highest training load that they can do. Because we know that generally speaking, health adaptations, fitness adaptations scale with that. The more exercise that people can do, the more results they tend to get, with two caveats. Caveat one, time. First bottleneck. Caveat two, how much can they actually recover from, right? And so like those are the two sort of limitations. One's logistical, one's physiological. And so I think that as people maybe outkick their coverage, too much training load for what they can actually recover from. Yes, overuse injuries, injury risk more broadly speaking, burnout, whatever, staleness, things of that nature, but truly becoming overtrained to the point where, oh, we just back it down a little bit, and then and nothing still happens, and they're still on this downward decline, and it's not more attributable to a medical condition, a psychosocial situation, any whatever. It just doesn't seem to really happen. And so my whole point of doing that podcast and talking about it or whatever is that most people don't exercise. Most of the people who do exercise aren't exercising enough. And when I say enough, it's to this sort of theoretical optimization, like to get the most health benefits, to get the most performance benefits or whatever. And so the idea that you should be putting up this obstacle, like, well, don't do too much, I
It's a
vehemently push
boogeyman.
back. It is a boogeyman, and that's in the training situation. In the clinical situation, it's this sort of extreme exercise hypothesis. This thought that if you do too much exercise, your heart is going to do weird stuff. You're going to increase your risk of heart disease because of left ventricular hypertrophy or whatever. There's this thought that if you, even in conditioning, if you do more than 3,000 met minutes of exercise, you pass this threshold. Oh no, your risk of heart disease goes up. But when you look at the actual data, that disappears. So anyway, that was the sort of impetus behind doing this. And my main message to folks is like, try to overtrain. And I think some people take that literally, like, okay, well, look at what I'll do, doc. I'm like, all right, well, maybe we temper that a little bit, but yeah, that's the whole thing. Most people aren't exercising. Of those who are, most people could stand to exercise more if they had the opportunity to. And overtraining, yeah, it's boogeyman. I think that's a great way to say it.
I think the industry likes to grab onto proverbial boogeymen. I'm now starting to see this, and I call it a virtue signal, where people are saying that we're too obsessed with protein. You know, and again, you go to Dr. Stu Phillips, listen to the recommended protein guidelines. Great. And I also know that this is sort of an anti-supplement narrative too, and I think there's some validity there as well.
Sure.
But at the end of the day, if we look at the vast majority of the people we're dealing with and we're trying to reach, are they eating too little protein or are they eating too much protein? Right?
100%. Yeah, yeah, yeah. And I think maybe people are, do you think there's any fatigue signal in there, right? Where people are like, we've been hearing about protein for 20 years, 30 years. It's like, I'm sick of the damn protein talk.
But we're also not our audience, right?
Yeah, yeah, fair
We've
enough.
been
Fair enough.
immersed in it for a really long time, and then so I mean, I'll give sort of a shout to Dr. Gabrielle Lyon. Gabrielle's a friend. I've had nothing but the best experience with her. But Gabrielle will sometimes, be the target of people who want to be a little bit technical about stuff, and you know, and a lot of her messaging is protein based, right? And as far
Mhm.
as like encouraging people to eat more protein, well, you, the person who wants to try to pick apart technicalities in her arguments, aren't the people she's trying to help and reach. And she's done a pretty goddamn good job of getting into the mainstream as a personality and a brand. Do I
Mhm.
think that anybody that I know, even guests I've had on the podcast, are bulletproof 100% of the time with everything they say? Nope, I don't think so.
Yeah.
But on the balance, I think she's doing a great job.
Yeah, yeah. I find little harm also. So like I guess the way I think about it is like when you say something, what are the stakes? at play here, right? If you tell somebody to eat more protein, you don't get all the technical aspects of it right. Okay, so people eat more protein, maybe a little too much protein. The stakes are low. Oh no, you happen to eat more likely minimally processed or unprocessed foods that displace other foods, and your protein intake is maybe a little bit beyond what you could actually optimize for. The stakes are low, right?
Mm.
Now, on the other hand, and not to pick on Dr. Lyons, because I look over the last 15, 20 years, I'm sure there's some things that I would like to have back, and
Mm.
somebody could point the finger at me. But one thing that she repeatedly says that I do think the stakes are high, by contrast, is her thought about obesity is that it is fundamentally, it is a disease of low muscle mass. That's the problem. The problem is not the excess fat mass. The problem is the low muscle mass, which unfortunately it would be very challenging to support that with evidence. Generally speaking, individuals with obesity compared to lean counterparts are carrying, if not the same amount of muscle mass, but more on average, kind of like carrying around a heavy barbell all day. Yes.
Thank
And
you.
then the problem with addressing it that way is if you were an individual with excess adiposity, excess body fat, and you were just told and believed that, well, look, the problem is I just need more muscle, then the solution to that isn't weight loss, when the solution for excess adiposity is weight loss. Now, I should be very careful when I say this. In obesity, we do think that muscle is important, right? And we would prefer an individual with a BMI, let's say over 35, right? Obesity and a large waist circumference. We would prefer them to, if they happen to have excess body fat, we would also prefer them to have a lot of muscle mass too. We prefer that to be the case rather than sarcopenic obesity, which is like
Mm.
you get a double problem with not only poor functioning muscles, but also excess adiposity. Now, the tell here and the reason why I'm kind of focusing on this and have an issue with what Dr. Lyons said is that the bigger problem in sarcopenic obesity is not the muscular dysfunction. It is, in fact, the excess body fat. And so the
Mm.
treatment, the focus has to be on the excess body fat, which, for example, GLP-1s do a very good job of. Metabolic bariatric surgery does a pretty good job of as well. And lifestyle, of course, is underpinning all of that. So, again, none of us, to your point, are without sin, if we want to do that.
Mm.
But yeah, I think ultimately, when you communicate stuff publicly, and if you find a gripe with somebody, you may not be their audience, which is fine. You should probably let that slide. If the stakes are high, though, as you've probably seen on threads a few times, I'm like,
Mm.
we should probably needle on this a little bit. I got some stuff to say or question initially. That's kind of my first goal.
I'm glad you got onto this thing. So the first point, and it's sort of an anecdote that almost proves a rule, is look at almost anybody you know who is obese or has been obese. Look at their calves. Look at
Oh yeah.
their legs. They're thunderous. They're big, right? There are not a lot of these people outside of people who probably have been chronically sedentary to the point where they just don't move around on a daily basis and then
Hmm.
extremely obese, in which case they're so metabolically unhealthy, they're going to be facing, significant mortality risk, right?
Hmm.
But almost all the rest of them, especially if they're ambulatory, if they're moving around on a daily basis, there's tons of muscle bearing that weight. I'm going to say something because this is a bridge into our next thing. A lot of people might disagree with me, but there's a lot of pushback from a lot of corners about GLP-1 agonist medication use and muscle loss, what have you. And I'll be careful how I say this, so hopefully people don't take me out of context. If you had someone who is morbidly obese and they're not doing anything, and if the only thing that they did was get prescribed a GLP-1 agonist medication and they lost a significant amount of weight through the mechanisms it works by, and they do not start with resistance training, I think that's a net win. It probably gets that person on a pathway to better nutrition. It's going to improve their metabolic health. And maybe that's the gateway to get them able to get into a gym or do more physically active things. Do I want the sarcopenic obese person who isn't active? Do I want that person to go on GLP-1 drugs and lose even further muscle mass? No, I absolutely
Mm,
explicitly
yeah.
don't, right? But I'm talking about the person who's morbidly obese. So thoughts?
Yeah, no, that's a excellent. 'Cause I was going to get there, and I'm glad you led me into this nicely. So I think to your exact claim, where a person with obesity, right, if they were to just start on a GLP-1, they were unamenable or inamenable, whatever the word is, to starting some of the lifestyle changes, which would include resistance training, certainly. Would they be in a net better place by starting the medication compared to not? And the answer is yes. But the concern is very similar to kind of what Dr. Lyons is talking about. Look, it's just too little muscle mass. You put them on this medication, they're going to lose a bunch of muscle mass. That's the problem. But the data doesn't show that at
Hmm.
all. So what the originally in 2022, the step one trial comes out. This is the first semaglutide trial long term on weight loss, right? And it showed that 38% of the weight that was lost was lean mass. Headlines everywhere. Stu Phillips made a claim like, look, we got to watch out for muscle loss here, okay? A few things that were missed there. One, the placebo group also lost 40% of lean mass, and they only lost like 2 or 3 kilos. So to me, that's an instrumentation error. But the bigger problem here is that while this was DEXA was used to determine the lean mass loss, DEXA misses a lot of very important and very unique factors in individuals with obesity. So, for example, in individuals with obesity, there is particularly chronic obesity, long-lasting, long-term obesity. There is a substantial increase in size in the liver. Now, some of that is just proteinaceous, liver material itself, more glycogen, more water, but also more liver fat. And liver fat, if we think about subcutaneous fat, the fat under your skin, and then there's visceral fat, fat surrounding your organs. Well, visceral fat's more dangerous than the subcutaneous fat, but fat in the liver is even more dangerous than the visceral fat. And what we think is that the liver fat, most dangerous, it overspills into the visceral compartment, and then you have problems from there. So when you use DEXA to look at the amount of weight that's lost in a GLP-1, of the lean mass that's lost, if you had to give me an estimation, how much of that is actual muscle contractile protein?
I wouldn't even have the context to make a guess.
Yeah, so I'll break this down. What they're comparing the 38% loss, right? So of the weight that they lost, about 15% of their starting body weight. The study suggested that 38% of that was lean mass loss. And you compare that to a diet-only intervention where it's normally 25% of every pound that's lost is lean mass or just not fat mass, right? Now, of that, I said it's just not fat mass, which means it's anything that's not adipose tissue. Well, not all of that is contractile muscle protein, okay?
Mhm.
In the 38%, that was found in the step one trial, and then 25% in the SURMOUNT-1 trial, that's on tirzepatide. What we think is that about 9% of that weight is actual muscle protein tissue, contractile muscle protein. The majority of it is liver and liver fat mass, which DEXA picks up as lean mass loss,
Hmm.
and intramuscular fat. Individuals with chronic obesity have a substantial portion of fat that's stored in their muscles and fat that's stored in their liver, in addition to, generally speaking, larger livers. And the way that DEXA works, it uses two signals to differentiate between muscle and bone. And it uses what's called an attenuation ratio, the sort of relative signal that passes through tissues to say, oh, that's lean mass versus fat mass. It is not sophisticated enough to pick up fat that's inside of lean tissue, like a liver and like muscle. So, in an estimated 3 kilogram lean mass loss in an individual, right? We think that 9% or about zero point 0.3 kilograms is contractile muscle tissue. We think that about 0.6 kilograms or 20% is intramuscular fat, glycogen, fluid, water weight, or whatever. And about 71% or about 2.1 kilograms is liver and liver fat mass. And this is basically on the heels of the SURMOUNT-3 trial. This was a MRI study that they used tirzepatide to look at how much intramuscular fat did people lose. And in these new phase 2 trials on survodutide and retatrutide, and these are different drugs, they're triple agonist. It's GLP-1, GIP, and then also a glucagon receptor agonist. And that last one is really good at taking the fat out of the liver. So the majority of the lean mass loss signal we're seeing in GLP-1 and GLP-1 adjacent medications is from liver fat loss. So to make an even more pointed claim that perhaps is more provocative, if you were to compare an individual with obesity who was somehow, through Herculean efforts, able to lose as much weight as they would on a GLP-1, right? But they did no exercise, so just diet only, right? The lean mass loss in them would likely be higher than it would be with a GLP-1 because the GLP-1 does a better job at getting rid of liver fat than diet only. And so that is perhaps the more provocative claim, which I do think I have evidence to stand on there. And so that, mainly watch this space as more and more data emerges. But yeah, the lean mass loss is incomplete. It was incomplete, an incomplete story when looking at diet only interventions because DEXA, people view this as like the holy grail. Well, it's not. MRI and CT are far better than that. And so it's capturing a signal on lean mass loss that is not certainly just contractile muscle protein. It includes everything that's not fat and including some things that are fat, but the signal can't just tell them apart, like fat in the liver, fat in the muscle, for example.
You answered my question. I was going to go right there and ask, well, do we see the same sort of effect, especially with liver fat, when you have weight loss independent, like comparable weight loss independent of GLP-1 agonist
Yeah,
medication or similar medication use?
you do. It's just not as much. And we think, and now part of this with general, if you just compared real world application of diet only versus GLP-1, the problem is that people with diet only don't lose as much weight. So that's like strike one. But theoretically, if you did, the GLP-1s just seem to do a better job, especially if they contain a glucagon receptor agonist like retatrutide does and survodutide does. It's an agent coming down the pike, tirzepatide as well, as particularly for intramuscular fat. So yes, to your point, all weight loss will affect these compartments some way. So the DEXA measurement of a diet only, in somebody who did that and lost weight would be off a little bit. It's just off more when it comes to GLP-1s and these newer agents. And so to me, it's very exciting. Like what happens when you lose intramuscular fat, right? It is counted as lean mass loss, but then what you see in like the semi-lean study where they put people on semaglutide for a year, they not told them not to exercise. And to your point about individuals with, let's just call it frank obesity. These people had BMI on average of 46, I believe, when they started. And so they had the criteria for sarcopenic obesity, about 46% when they started the trial. A year later, no exercise, just semaglutide at max dose. That went down by about a third. These people didn't exercise, but less than a third, more than a third of them had no longer met criteria for sarcopenic obesity. Their hand grip strength went up during the year without any exercise. And so what we think is that the intramuscular fat actually interferes with muscular force production. And so despite not exercising, their muscles now work better. And so if you were this muscle fanatic, Dr. Lyons, shout out, you would love these medications because they make the muscles that you have work better. Now, to all of our points, if you did resistance training on top of that, ooh, then what happens? There's some new preliminary data coming out of what's called the T-Rex trial. This hasn't been published yet, but it's people who are taking GLP-1s and resistance training. It looks like the lean mass loss is cut in half, which is very similar to what you see with diet-only weight loss, except for the people are losing a lot more weight. But what that means is that of the, you lost 38% of the mass that you lost was lean mass. Well, now it's an even smaller subsection that's actual muscle protein. And so at that point, you're like, I'm not worried about this at all, to the extent you were initially after what I just told you. So to your point, I am not worried about losing too much muscle mass. It's theoretical on some level, but also like not really what happens. I think it's a boogeyman to use that term again. But yeah, add some resistance training, you're going to do even better.
I recently had Dr. Katie Dabrowski, so she's a doctor of
Oh yeah.
physical therapy, very evidence-based, brilliant. And I had pulled her on specifically to talk about how obesity and metabolic unhealth played a role in rehabilitation, in particular
Mm.
to what you just said about fat tissue in muscles and tendons and how it interferes with um, strength, motor control, all these sort of aspects of movement. And what you just said coincides very closely with what she said. So if anybody's interested in listening, she actually gets more into this on a rehab and injury recovery uh, side of things, but it coincides perfectly.
Yeah, we also think, there's like a metabolic signature to this too. When you see this myosteatosis, fat in the muscle, obviously muscle is one of your biggest sort of reservoirs or depots or sponges for like blood sugar, for example, but also the muscle itself is like an endocrine organ. It produces these myokines, which are little, hormones effectively that do a lot of cool stuff. They reduce inflammation, they signal tissues to regenerate, and so on and so forth. And the fat that's stored in there kind of compromises that as well. In addition to like bone health and tendon health and ligament health and all that other sort of stuff. And so what you would want to do if you in a perfect world is you would want to extract all of the fat out of the muscle that was non-adaptive. Some endurance athletes actually get to store more lipid in there as like an energy source. So that's not really what I'm talking about, but in individuals with obesity. And you'd want to get rid of all the liver fat, right? And you'd want to leave the muscular compartment alone. So how would you do that? Well, you would take a GLP-1, sure. You would have the person resistance train, sure. You would have them eat more protein. Probably the biggest issue with GLP-1s is because they lower the amount of calories that people take in. they're going to take in less net protein overall. And if they develop any sort of aversion to proteinaceous foods, protein containing foods, that's a problem. So you don't want to have them eat enough protein. Yes. And then you might also want to add a muscle preserving agent like a selective androgen receptor modulator or like some of these other exercise mimetics. There's been two trials published recently. One is the Believe trial. That's with enobosarm. That's a selective androgen receptor modulator. They effectively cut muscle loss down to less than 10% of what they found for lean mass loss, which
Mm,
is really interesting. And then the other one was the Quality study where they use activin 2 inhibitor. Basically, it's like a myostatin inhibitor. And they showed the same thing, basically preserving all of the muscle mass. And so
mm,
some people listen to this are like, what are you, big shill for big pharma? What the heck, dude? You're just talking about drugs. And I'm like, look, I would prefer that people just lift weights.
mm.
Not because I'm averse to using medications. You don't get a gold star at the end of your life for doing it all natty, bro. You don't get a pat on the back for that as you go in the grave. But there's a subsection, a cohort of people who not only benefit from these medications, but also are either unable to or unwilling to, can't exercise.
Mm.
And you're like, well, so what? They're just up a creek. Let's give them a helping hand. And what we see in the literature behaviorally with these drugs, with these medications, is that people tend to be more active on average,
Mm.
which is exactly what you'd want. And is some of that like a positive reinforcement thing? They're like losing a little bit of weight, they feel encouraged, and so now they want to go exercise. Probably is part of it. Sort of like, well, now they don't have as much weight that would otherwise prohibit them from doing the lifestyle stuff. Probably, I'm not saying it has to be one thing, but ultimately, when people are like worried that someone taking GLP-1s is going to be a net negative on their life, it doesn't really show up, outside of like relatively rare side effects. It just doesn't really show up. And I'm more like, might be the best thing to ever happen to society from a medication standpoint, outside of maybe vaccines. Maybe you cut that so some of your listeners don't click off.
They'll be
But
fine. They'll be
the,
fine.
and maybe one of the worst things to happen for what I would consider entrenched sort of health and fitness coaches that are like that really immoralize the sort of
Mm,
lifestyle stuff where it's like you got to pick yourself up by your own bootstraps. You can't accept any help. In which case, I
mm.
wonder how many of these coaches are saying to an individual who comes in and inquires about their coaching services, like, "Hey, have you tried doing it on your own? Why don't you take a year and just try it on your own? And then if you fail that, then at that point you can hire me because I need you to I need you to fail first, right? Because what they're effectively saying is like, don't use this, unless you have to, right? That's like the most charitable interpretation. Some people say don't use it at all; it's dangerous, which we can ignore. But I'm like, why do you got to fail first? Don't do that. The whole point of treating obesity, just like treating high cholesterol levels, high blood pressure, whatever, is you're reducing the exposure to a known risk factor. And the degree of benefit that someone ascertains by reducing that risk factor is due to not only how much the risk factor is reduced, but for how long the risk factor is reduced. So delaying it doesn't make any sense to me.
Uh,
I'll interrupt this episode for a quick but important side quest. While I don't think everybody needs to track nutrition all the time, tracking is one of the most powerful tools to make sure you're not eating too much or too little. And Macros First is my go-to app for me and my clients. Macros First has a free barcode scanner, and a premium version comes with a bunch of cool stuff to make managing your nutrition easier. Like, one, AI search. AI is everywhere now, where you can speak or type the foods you wish to save and log everything without having to search for each individual ingredient. Two, import recipes from a website. Save time creating recipes manually by importing all ingredients and instructions from your favorite recipe websites. No more searching for each ingredient one by one, just paste in the website. And three, this one's a big one for nutrition coaches. Follow unlimited friends so you can follow all your clients. And there's a lot more cool features. You can try the premium version of Macros First free for 14 days. Just download Macros First from the App Store. And during setup, you'll be asked, how did you hear about us? Type in the code Andrew.
a few things I'll riff off. One, you mentioned the sort of the future of some of these things like myostatin inhibiting drugs. So I'm actually recording with Dr. Mike Isertel,
Oh,
RP is one of
perfect.
my sponsors, right a couple hours from now. That episode is going to come out in a couple of months because he's actually got a book that goes into this, but a lot of it is of the future, like the optimistic side of what potentially is going to materialize with these kind of things in trials, and it could really change, a lot of our lives. So, guys, stay tuned for that one. Two, I mean, the implication for that kind of medications when it comes to cancer patients, to anybody with neuromuscular issues, I can see things like multiple sclerosis, and maybe it's too ambitious to think it would have any effect on something as aggressive as ALS, but who fucking knows? But either
Yeah.
way, any wasting sort of diseases whatsoever, the elderly, you name it, there's just a mountain of implications there. And then, you went somewhere where I was going to take you, so I love this the morality side, the resistance to GLP-1 medications and similar class medications. I have a theory, and I think you kind of hit on it. I see broad resistance, and I think it is in fact because a lot of fitness professionals feel like they're going to lose relevance and access to people. I think
Mhm.
they're going to lose status, and I think it so. Sometimes socio-political spectrums enter our world. And I think more on the, let's call it the right side of the spectrum, it tends to be a bit more, well, I have this great physique, therefore I have special status, and, and then they bleed that into their business. And of course, there's the, yeah, you have to do it naturally. Meanwhile, some of those people aren't natural. So there's sort of a blatant hypocrisy baked into that whole thing. But I think they're threatened that, well, everybody now could theoretically walk around looking like them. Meanwhile, genetics and
Mhm.
drugs are probably big players in that whole thing. And then, but the funny thing is, the other side of that spectrum, I've noticed they're doing something different. They're also resistant. They're threatened because I think they're scared they're going to lose business too. And they're better at dressing it up, but I see it sometimes in things like objection to people taking it for aesthetic reasons or anybody taking these drugs outside of
Mm.
medically prescribed being diabetic, etc. But I think all roads come back to the same thing. I'd love to hear your take on this, but I think a lot of people are actually scared of no longer being relevant and not having people hire them for their overpriced, high ticket, low effort bullshit online coaching.
Yeah, I mean, some of this it reminds me a little bit of like the sports mythology sort of thing, where it's like, oh, because a person is good at catching a football, throwing a football, or whatever sport of your choice, they're like a good person for doing it. Like they worked hard and whatever,
OJ
and
Simpson. Yeah,
the
let's talk about
virtuous.
OJ Simpson.
Yeah, yeah, we keep going down. There's a long list, right? Like, so anyway, some of that is like, yeah, if you look at my physique, that means I have this work ethic, and it says things about me that go beyond just my physique. So, separate issue. To your point, though. I do think that the calculus, the risk benefit discussion changes when we talk about maybe let's call it like off-label use, or better yet, maybe like recreational use
Mm.
of these agents, right? And so you imagine a person who wants to use a GLP-1 to lose like 5 pounds or something like that, or 10 pounds, whatever, make it more aggressive. But would not really benefit health wise. Let's just assume they've got effectively no fat in their liver, no fat in their muscles. We're just talking about they want to prep for a bodybuilding show. They're already relatively lean, but instead of suffering through, the arduous task of reducing calories, being hungry all the time, they're like, I can just take this medication and like I'll be good. Makes the behavior change a little easier. And in fact, that's the way I view these medications. They're just behavioral change agents. They let you do the thing that you've always wanted to do, which is eat the health promoting diet in an energy restricted state. Anyway, I think that that's something you weigh on a case by case basis. Again, my view, I'm not paternalistic about this. I don't have any moral like hangups on it. Like if the net benefit is greater than the knowable risks going into something, and somebody can really have like informed consent and choice on this, then like they're autonomously, presumably functioning adults, and they can make that choice on their own and living better through chemistry. Okay, like it to me yeah, you would just really have to hedge that we don't know the risks for this particular population. A person who is relatively lean already, short-term use, we don't really know the risks. No signal has popped up where we're like, absolutely do not do this.
Mm.
And that's for like a person prepping for a bodybuilding show, getting ready for vacation or whatever. I think things get a little bit more clear as far as the risk outweighing the benefit when you start talking about maybe a perimenopausal woman who's already relatively, let's say, lean, but reality she's more skinny than lean, and you start worrying about bone mineral density. And the reason
Mm.
here is because when you lose mass, any sort of mass, fat mass, muscle mass, it usually comes together. You're going to lose a little bone mass. And if your physiological reserve is already compromised due to where you're at in your life, that becomes a different concern, mostly if people aren't resistance training. There was a study
Mm.
came out in 2024 and a follow-up by the same group. They took people on liraglutide, which is one of the older GLP-1 agonists. Doesn't really cause as much weight loss, but have done a number of studies on this. With resistance training, there was no change in bone mineral density. And so you're like, okay, so you can mitigate this, but that's where I think that sort of risk really starts to outweigh the benefit when you start worrying about things unrelated to like muscle and fat specifically. You start to get into like bone stuff or even like low energy availability in individuals, which is defined as it's like I think it's in men it's less than 30 kilocalories per kilogram of lean mass, and it's a little bit lower for women. So if you had an individual with like a disordered eating and they had access to this, then again, the risk would probably outweigh the benefit. But like to me, those are relatively fringe cases. And if I were treating a patient and they were like, "Hey doc, I got to get ready for Cabo. I want my abs to have abs and I don't want to suffer for it. I'm going to keep working out. Don't worry. But like, let me get a little semaglutide." Uh, to me, at that point, we have this conversation, risk benefit. And then I'm more like, if you're going to use it anyway, I'd prefer you
Mm.
did it under my care with my monitoring and follow up and everything else than kind of DIYing it, particularly like gray market research peptides. So like at that point, I think it's harm reduction. So I don't know. Yeah, I'm sure there are providers out there that have a different view than I do, but that's kind of how I look at it.
Now, I really appreciate the measured approach to all this. So you mentioned bones. I actually tease up something else I had prepared, and there's a quote from you. The window for building bone density closes while most women are being told to do Pilates. I would love to hear you explain that.
This might have been one of my first like viral posts, at least on Facebook anyway.
Oh,
I
did the
think.
Pilates community come at you for that one?
Oh yeah, of Pilates community and just women at large, where, what I said in the post was that, yes, that was the graphic. And then the text was like, look, here's evidence of how you can, reverse is a strong word, which is what people kind of came at me with. I said, you can combat bone loss by lifting heavy weights. And here's the trial. It's the Lift More trial. Lift More trial was done in 2018. It was like 101 postmenopausal women who had osteopenia, so bone loss, not yet progressed to osteoporosis, for example, right? And they lifted heavy weights, 85% of their one rep max, 5 sets of 5. Now, some of the training bros, and they're like, you can't do 5 by 5 with 85%. I'm like, okay, well, look, it's a training max. These are untrained folks. Like, it was heavy
Actually,
enough, right?
and may I?
Sure.
This is something that shows up anecdotally with women. We see that women can do more reps closer to their one rep max,
Yeah.
anecdotally than men can. So at 85%, I wouldn't be surprised at all if a lot of women can do five. Now, there are potential explanations for this, and it also can be framed as women tend to, and again, I train full time in person, 15 years. I've seen a lot of this stuff. We also seem to see a quicker drop off from, that 5 to 8 rep range to what they can do
Oh,
for a
one.
one rep max.
Mhm.
So it just depends on how you spin it. But either way, objectively speaking, if you know what a woman's true one rep max is, you come a little shy of that, she could actually do more reps than a man on average.
Oh yeah, totally. And the way I think that the researchers did it is they took these untrained women, they tested their one rep maxes, which by definition, that actual training improved their one rep max. And so now instead of
Mm.
85%, it's 82, whatever. They didn't go into detail in the study, but the whole point was at the end of the study period, their bone mineral density improved. It was 4% in the
Mm.
lumbar spine, 2 and something% in the hip or whatever. And I'm like, this is great. So the point is you have to lift, right?
Mm.
And it has to be heavy enough to reach across this threshold for which bone mineral density actually is given a signal to accumulate, to accrue. And that doesn't mean it needs to be maximal. It doesn't need to be 85%, but it needs to be heavy enough. And this is sort of collectively factored into what's called as the osteogenic index, right? It was basically a fancy way of saying, is this enough to stimulate the bone? And Pilates is certainly not. This has been studied directly, not well enough in my estimation, because Pilates is kind of, I don't know, it's weird. It's on this island, and people studying all sorts of dumb ways. Um, but Pilates isn't going to cut it. Yoga's not going to cut it. Aquatic, water aerobics isn't going to cut it. And that's the point. Women in their 20s and 30s, that is definitively the prime window for which they can accrue bone mass, bone mineral density. It's like if you could, you think about a financial analogy. If you knew that in your 20s and 30s, right, and we were living, maybe in the 80s or whatever, you could just invest in Apple, or Google or whatever. And then,
Yeah.
years later, you get the payoff. That's what this is. It is the prime window. Most of that has to do with the hormonal milieu, the hormonal situation on board. But yeah, that's the prime window. You can basically build a big nest egg of bone at that time. And anytime after that, it doesn't mean you can't build bone, just not as much. Right. And so that's the prime window. You can have your matching athleisure wear set, no harm, no
Hmm.
foul. But instead of only going to Pilates, you should do some heavy lifting. That was sort of the message. In the comments, people are like, Pilates does this and this and this and this. And I'm like, actually, Pilates does a pretty bad job at almost everything when it comes to muscular strength, muscular hypertrophy, certainly bone mineral density. And people are like, well, what about core strength? I'm like, sure, specific to what you're doing in Pilates, but like you could do that stuff in other training to get general development of those muscles. They're like, well, what about balance? I'm like, that's been studied, not so much better. I mean, like, I don't know what you want me to say. It is a fine recreational activity, just like yoga, golf, or whatever. But the idea that this is building bone mineral density has not been shown. In fact, just the opposite. And so the point is that if the popular narrative, Pilates are trending, which is what the message is right now, I have concerns that instead of doing that, people would be better served by lifting weights. And that's what I feel like. I rarely see the opposite case where I'm like, this person's doing too much lifting. They're just getting too strong and too much muscle mass. And in fact, they should do some more Pilates. I never see that. I only see the opposite. But yes, the Pilates people came from me. The women who were in their 50s or 60s who weren't currently lifting were like, are you saying I'm just cooked? I'm like, well, no. But if you already have osteopenia or osteoporosis, reversing it is a tall ask, particularly from exercise alone. If you combine exercise with dietary change and some of the anabolic agents that we have for building bone mineral density that are available, you can get close, and some individuals will be able to reverse that full stop. That can happen, but with typical use and adherence rates and access and this, that, and the other, it's just a tall ask. If you're a 65-year-old woman, your bone mineral density is way, way low, we can get you improved, but reversal is just a really big ask. And I think that was lost on people. They're like, you're just saying it's black and white. And I'm like, I almost never say things are black and white, but it is the internet, so I should have predicted that.
So what you're saying is women in their 50s and 60s should blast trend. Is that what I'm interpreting? No, guys, please, no.
Please don't do
Uh,
that.
Please don't do that. Okay, second, like ridiculous statement. So in this ridiculous false dichotomy that hopefully doesn't exist, if someone had to choose between only taking GLP-1s and only doing Pilates, you would rather have them do the GLP-1. I'm actually again joking, but I suppose
An
that
individual
one's
with obesity, 100%. Yeah,
okay.
yeah, 100%.
All right.
A quick sponsor break for my current aspiring coach listeners. This episode is brought to you by Train Heroic. If you know me, you know I only work with sponsors I use personally and where I know the people behind the product. Train Heroic is the best online coaching software in the industry. Not only is it a great platform for one-on-one coaching, it's fantastic for group coaching and selling standalone programs. Train Heroic is used by some of my trusted friends, so I switched my online group program here, and my members love it, raving about its ease of use. Having a dedicated app means far greater reliability for my clients and has been by far my best experience with any online coaching software. Train Heroic is a proven and stable industry leader, meaning it isn't going to suddenly disappear. One of the biggest risks in choosing an online coaching software. When you start a free trial today, you'll get 90 days free to experience why I love and trust this platform. You'll get full support from their team, who've been a joy for me to work with. And I trust Train Heroic and the people behind it. Here's how to activate your free 90-day trial. It's 2 important steps. Number 1, go to www.trainheroic.com/liftfree. Step 2, reply to the email you get. It should be trials@trainheroic.com, and let them know I sent you, or go to the links in the show notes.
So fun aside, actually, this has been one of my favorite episodes in a while. You know what? I would love to give you a good treatment on this one. Is there a relationship between form and injury risk? This is one of those super pervasive things. I'm doing a talk literally this weekend, so it'll be done by the time you guys hear it aired. That touches on this stuff. So yeah, go.
That's a great question. And I think it comes down to, how people view form as a sort of modifiable factor and the influence on injury risk. And maybe just zooming out, like what is the injury risk generally speaking from exercise? Well, for resistance training, it's relatively low on average across all different types, 2 to 4 injuries per 1,000 participation hours. You compare that to like recreational cycling and walking, those are like 1-ish, 1.25, and so not that far off. And then you compare it to like recreational running, which is 10 injuries or more per 1,000 participation hours, actually higher in novice runners, like 17 and some change. And so you're like, maybe not that risky. You compare it to like football and rugby, you're talking, 50 to 80 injuries per 1,000 participation hours. Or my sport of choice, motocross, 95 injuries per 1,000 participation hours. Who would do such a thing? So the whole point is this: injury risk is relatively low. Then you have to go into, well, what is the nature of most of these injuries? What is the nature? Are they acute, catastrophic? You ruptured a disc, or herniated a disc rather, you ruptured a tendon, a ligament, a muscle? Generally, no. On average, most injuries that are reported in resistance training resolve on their own without specialized treatment in about 2 weeks. They tend to mostly be fatigue-mediated injuries, which basically is a fancy way of saying it's kind of an overuse injury, but not really, because it does resolve within 2 weeks. The longer lasting ones are chronic, so more overuse stuff, which just means you're doing too much, not that you did it wrong acutely. Okay. So with that framework, now you start to look at technique. Technique is basically a self-selected style of completing a task. It has to do a lot with what is your mental model of the thing you're supposed to do, your individual sort of strengths, weaknesses, anthropometry, etc., training history, so on and so forth. It changes dynamically across your career. And so is there evidence that adopting a particular technique reduces the risk of injury? And by and large, there's no evidence to support that. In fact, advanced lifters, when you put them under very, very well-observed conditions, a lot of high-speed motion cameras, they have rep-to-rep variability in all 3 dimensions. Okay, so there's variability at baseline. And the whole point of this is to say the technique is not really one of the main modifiable risk factors for injury, because if it were, you would expect to see acute injuries be very common. They're not. And since they're not, we look at overuse injuries and like, are those related to technique, or are they more related to training load? And in fact, it is the training load issue. And so that begets the final question. You're like, well, look, I did this thing wrong and, I had this injury. What you say, and it wasn't related to technique. And I'm like, well, look, if it wasn't an accident, high velocity movement, poor motor control, you fell, you tripped, you dropped a weight on yourself or whatever. In fact, that is what I'm saying, that it is not the technique that caused this particular straw to break this particular camel, your back. All right. It was more of the global training load, and this just declared itself this particular time. Adjusting technique can be a useful way to manage symptoms if it changes how the load is distributed on the individual. But the thing is, we are very adaptable, very resilient, very robust. And the idea that just doing the thing wrong, that's going to be the linchpin, unlikely. So the analogy I like, that you can think about your sort of tolerance for training as a bank account. Right? If you got $1,000 in the bank account and you try to make a $1,200 withdrawal, you get an overdraft fee. We call that an injury. Now, the technique people are going to say, well, it's not that how much you try to withdraw. It's did you use your left hand or your right hand when you put your card in the ATM? And I'm like, well, that's silly in both cases. Realistically, you just want to make sure that your withdrawal doesn't exceed what you have in your account. And you can make $5 withdrawals all day long, all right? But you try to make one that's greater than what you have in the account. Yeah, bad things can happen.
Yeah, that aligns with what I think and what the evidence says. And you pretty much gave away about 4 or 5 slides of my presentation. So I love it.
Yeah, no one needs to go to the conference.
it aligns perfectly, which validates what I've got. So I like to think about it this way. Oftentimes when I'm seeing, and yes, it's hard to qualify what bad form actually is, but any experienced lifter, sometimes you can see something in gym and be like, oh shit, well, okay, that's bad form. We know what's going on there. But if you look, they're probably using improper load. And when we say load management, we're talking about globally. It's yes, sure, weight in the moment, but it's also sets, reps, it's volume, it's intensity, it's how close to failure, all these sort of things. But in some cases, someone is lifting too much weight that they are not in control of. They're not able to organize their body as they move that weight. And the form is then compromised. Was the form the problem or is the load the problem?
Yeah, I think the easiest way, and you can just like a on the fly sort of validity test or stress test. Someone's like, look, you can't squat with your knees going way over your toes. You can't deadlift with a rounded back or whatever. And you're like, oh, because the particular anatomical relationships, the particular postures and positions the person's adopting, you're saying that's the risk. And they're like, yeah. And I'm like, well, can they do it with a PVC pipe? And they're like, well, yeah. And I'm like, hmm. So what you're saying is it's not the posture, the position, the anatomical relationships that are so harmful. It's the load. And so are they adapted to doing that? So you think about, oh, you can never deadlift with a rounded back. Well, how do you pick up a stone? Or how do you pick up a child off the ground? Or how do you pick up something, in the farm, around the house, whatever? You can never put your knees over your toes. Well, how are you a catcher in baseball, for example? And so the point is that you can adapt to maybe these, well, let's even call them charitably, suboptimal positions, if somebody wants to say. If you are gradually exposed to them with a dose that you can currently tolerate and subsequently adapt to. Now, to your point, what is good form? Well, it's only been tried to be defined once in the literature, Collado 2009. And I'll read this direct quote from you. I just pulled this up. Proper technique includes performing the exercise with the correct speed, the correct resistance, in the correct plane of movement, and within the optimal joint range of motion to maximize adaptations and minimize injury risk. Sounds nice.
That's a circular narrative, though. It
It's a
doesn't actually define
tautology.
itself.
It's like,
Yeah,
look, the best form is the one that you don't get
it's the best
injured by.
form. Yeah,
What?
that doesn't tell
Your
me
best
anything.
technique to produce a reduction in injury risk is the one that reduces injury risk. You're like, oh, hey, thanks for that, Collado.
There's another thing when I think about form technique, and I like the word technique for this very purposes, I'm thinking more about what tissues am I trying to train and
Yes.
therefore put force on them. And so, yes, do I care about form? Of course, we both care about form. We care about technique from a point of, all right, can we load tissue so that way it adapts and gets stronger? And also, do I care about how the body organizes in space to more efficiently perform some sort of exercise? Absolutely. Those things matter. I'm much more concerned about those than necessarily injury risk. And to your point, I always use the example of my cat, Ozzy. He's about 14 pounds. I mean, if I like brace my core, bend down to grab him, depending on the mood he's in, he's gone, right? I'm not going to be quick enough to catch him. So if I want to pick him up, I kind of have to bend over to the side. I'm rounding my back, etc. Now,
Oh no.
here's the other side of it. I mean, half of the tweaks I've ever had is me like scratching my back or bending over in the shower or just like something totally innocuous. This shit just happens, right? So, and I don't think that was a technique thing. I think it's just like shit happens.
Yeah. The way I practically apply this, I kind of created this own model. And if you find holes in it, let me know because I'm good. I want to change it if it's not good. So when I think about, all right, if we can't really define perfect technique, perfect form, or whatever, maybe let's come up with a heuristic to use. Like, well, in the gym, practically speaking, what is good technique? What is acceptable technique, right? And so the acronym I came up with is REP, REP, this REP model for good technique. R standing for repeatable is what you're doing repeatable. You can do it mostly the same rep to rep. Yes, there's going to be some variation, but like, does one squat look like a squat? The next squat looks like a good morning. It's probably not as repeatable as we'd want it to be. Okay. Two, E, is it efficient? Meaning that all of the force that you're imparting into the implement, the bar, the dumbbell, the kettlebell, the machine, the whatever, is it all going into moving the load rather than doing other stuff? That's from more of a performance standpoint, right? Because you want your stuff to be efficient so you can lift more weight so you can win the powerlifting meet and impress other dudes. That's what you want. And then P, does the technique that someone's adopting meet the points of performance, which is exactly to what you just said. If you're trying to target or load a particular muscle group or muscle groups, then it has to be done in you're putting up some boundaries, some constraints here, right? And so if you view technique from that perspective, is it mostly repeatable? Is it fairly efficient? Does it meet all the points of performance to the right depth, the right tempo? It's loading the muscles, at least as best as I can tell, from an anatomical sort of first principle standpoint. The technique is good enough. At that point, the biggest lever you have to pull for injury risk reduction is going to be load management and not like, well, did your L3, L4 have some minor flexion, off the floor? It's like, come on, dude. No, it's like your body just wasn't adapted if you did happen to get an injury from the training load that you're currently exposing yourself to, which is good news on one level, because that's a way bigger modifiable lever than like how you move on like a micromanaging anatomy, which I think is more challenging to do.
And then more acutely, manage sleep, manage hydration. Those two are two of the biggest acute risk factors for injury. And I mean, now I'll flip this and say we also seem to have good data. I'll conclude on this point that if you're short on sleep, then you can attenuate some of the negative effects of short sleep by actually going and working out. So it's
Yep.
not to scare people away from working out, but those are still things you want to work on.
Yeah, try to sleep, get enough high quality sleep every single night. That would be great. Big health benefits there too, obviously.
This has been fantastic. I'm going to have you back. At Jordan underscore Barbell Medicine is your personal handle. Obviously, you guys have the Barbell Medicine brand. Anything else you want to direct people to?
Only thing is we do have a book coming out is on testosterone. So to the extent you're interested in testosterone, this is our sort of pushback against the industry, which sells you a number as the problem, but the number isn't really the problem. It's almost always a downstream signal of something else, usually excess body fat, poor sleep, undertraining, chronic disease, something like that. And so the book is called Signal. It's going to be out either end of next month or June, somewhere in there. So if you're listening to this, you're curious about testosterone and you want an evidence-based take on it, that'd be the book.
Oh, fantastic, guys. Go check that out, please. Obviously, everybody tuning in, thank you. This is one of those episodes. I hope it knocked your socks off. Share it with someone in your world. You can help me grow the podcast. More people find Jordan. Their podcast is great. Thank you. Appreciate you taking the time to come and talk to me.
Absolutely. Thanks for having me.